Good afternoon, everyone. Greetings from UAP Old Mutual. Apologies for the delay in beginning the webinar today. We had a few technical challenges, but we are pleased to invite all of you to this webinar today to discuss COVID-19 vaccines. There have been a lot of questions around the vaccines. What are the facts? What are the myths? That's what we're here to discuss, and we are pleased to have the team from Aga Khan University Hospital, and our presenter today is Dr. Douglas Gaitho, an infectious disease fellow and a consultant pediatrician at the Aga Khan University Hospital. So we'll begin right away, and please know we'll have a Q&A session at the end, but you can start typing in your questions. Karibu sana, Daktari.
All right, so thank you very much, Dr. Elijah. Maybe just clarify, can you hear me well?
Yes, we can hear you.
All right, thank you very much. So I'm going to take us through COVID-19 vaccines, but before I even get to the COVID-19 vaccines, of course, it's been an evolving pandemic, as majority of us are fully aware about. And when we talk about prevention of COVID, the new kid on the block, so to speak, is the issue to do with vaccines. And so, but it's important for us to realize that the other measures and the precautions we have been taking to mitigate this pandemic still remain. So the outline of my presentation, I'll just give a quick broad overview of where we are in terms of COVID-19 pandemic. I know the transmission and the symptoms, these are things which are very well known to us, so I'll very quickly skim through that. We are going to then delve into prevention strategies, and as I mentioned, what we have been doing, the masking, social distance, hand hygiene, still continue even as we, roll out vaccine and hopefully roll out vaccine and get to a level where majority of the population is actually protected. But the focus of this presentation will dwell on the vaccines. I'll try and make it not to have too much of medical jargon. And then after that, I'll share a few slides from the Ministry of Health, which are basically looking at vaccine rollout and what the plan the government has moving forward in terms of vaccines. So I'll begin with something which is very well known to us, and as we see the introduction sections, nothing new. Majority of us are fully aware about this. So we all know that COVID is caused by a virus. The virus is called the SARS-CoV-2 virus. A pictorial image is illustrated on the right side of your screen. And you'll see it's spherical and it has spikes. Some people say it looks almost like a crown. And the reason why I've actually put that image is because when we talk about vaccines, it's important to understand that the vaccine development against the SARS-CoV-2 virus is actually to specific parts of the SARS-CoV-2 virus. So the so-called spikes, or what you're actually seeing on top of the of this spherical structure, is very important when it comes to infection. Because those spikes are important for the virus to be able to enter the host cells and actually cause an infection. And most of the vaccines which have actually been developed are actually targeting that part of the COVID, of the SARS-CoV-2 virus. Of course, when one is infected with SARS-CoV-2, they develop COVID disease. Majority of the people are asymptomatic or they have mild disease. There are those who end up developing moderate, severe, and a very few, about 5% of the patients, develop critical COVID. A lot of time, the terms isolation and quarantine are used quite loosely. And it's important for us to differentiate the two. When you talk about isolation, basically we're removing a person who has symptoms or is diagnosed to have COVID from interacting with other people. But when you talk about quarantine, this is someone who might have had some sort of potential exposure, but they don't have the viral infection, neither do they have any symptoms. So those ones usually go into quarantine. So you've heard a lot about home isolation, and that's basically home-based care for people who test positive for COVID. Travelers is a good example for people who, when you travel from one country and you go to another country, some of them do require what we call quarantine. Of course, people who are traveling have a negative COVID test, but it's thought that they've had some sort of potential exposure from where they're coming from. And so those ones go into quarantine. So it's important to be able to differentiate the two terminologies. I won't go into much detail in terms of the genesis of this particular pandemic. I think this is something that is well known to all of us. It's always on print and electronic media, literally on a daily basis. So I know this is something all of us are very familiar from the onset of the pandemic in Wuhan, China. The WHO task force that had been tasked to, go to Wuhan, China to try and determine, what was the origin of the SARS-CoV-2 virus. It's still thought that it originated from the wet markets in Wuhan, China, rather than being developed in a lab. And there was an intermediate host, which is thought to be a mammal animal. And I think the rest we all know. But I think when we talk about vaccines, one of the most important things to actually appreciate and probably give credit to China is that they were able to sequence the this virus and be able to understand its genetic makeup. And this was actually shared pretty on in the epidemic with a lot of pharmaceutical company. And this was actually the beginning of the design and the development of vaccines, which our discussion will focus on. I know what is projected on the screens is actually nothing new to us. We've been following this on a daily basis, looking at what are the cumulative reported cases and deaths world over. Unfortunately, over 3 million people have lost their lives because of COVID-associated complications. The number is slightly over 2,500 in Kenya, and with up to almost 150 million confirmed cases. And this was as of, WHO dashboard data as of this week. But then on the positive side is that the number of vaccine doses which are being administered are significant on the increase, just shy of the 1 billion mark at about 850 million vaccines already administered worldwide. Of course, there's a lot of discussion about vaccine equity. And of course, the majority of these vaccines have actually been administered in the Western countries, with the US administering more than 200 million doses of the vaccines. So and much less vaccine accessibility when it comes to sub-Saharan Africa. But we'll delve into a bit more of that as we continue with this. As I mentioned, I know this is something that is very familiar to all of us in terms of how is the transmission of the virus and what we can do to be able to mitigate that. So I won't delve too much on this. It's still thought that the most commonest route of transmission is via droplets. And so the issue of wearing masks and wearing masks correctly, in addition to social distancing, is really one of the seen game changers when it comes to mitigating this particular pandemic. The fact that the virus is suspended in droplets is important, because what happens is that as soon as someone talks or coughs or sneezes, is that those droplets will quickly settle on surfaces. And that's why we talk about, always practicing hand hygiene and, cleaning of surfaces regularly, especially where we have what we call, high touch surfaces, for example, doorknobs or door handles in public areas. I think we all know what the symptoms of COVID are, so I won't dwell much on this. They are the symptoms which we tend to see more commonly, and symptoms which we tend to see less commonly. I think in the social media, with the third wave, there's a lot of discussion that now patients with COVID are presenting differently. From a clinical perspective, we've actually not seen any difference in terms of how patients are presenting with COVID-19. It's still the same symptoms that we saw 1 year ago when we were attending to our first patients in Aga Khan. They're still presenting more or less in the same way. So really not much difference in terms of Prevention is very important, even as we talk about COVID-19 vaccines, as I mentioned. What we have already been doing, though not adhering to, probably 100%, still maintains the issue about wearing masks, which I've already highlighted. Practicing social distance is very important, and I'll actually highlight the impact of, the combination of these two prevention strategies and how that impacts when it comes to preventing COVID-19 infection. Of course, hand hygiene. We always do recommend that for those who are essential workers or people who are working in an office setting, for example, if anyone develops any symptoms, it's important to stay at home until the cause of your symptoms is established as a way to mitigate the spread of the infection to other people. As I said, I will still place a lot of emphasis because as the world, we are seeing certain parts of the world that are doing very well when it comes to vaccine. But even when you talk about a vaccine, I think one of the things that the pandemic has taught us is that we are one global village, and it just needs to take someone, boarding a flight from one corner to the world to the other to actually be able to spread an infectious disease. So as much as parts of the world are doing very well in terms of vaccines, I think until at a point where we are able to get to a level where a majority of the population has actually been vaccinated, these are measures which are going to continue for quite some time. So the issue about wearing masks and social distancing, and there's a pictorial on the right side of your screen, which majority of us can see, where even when social distance is maintained and one person who has COVID, in this case, the individual on the left side, if they cough, if they sneeze, or if they're asymptomatic and they just talk, then they do propel droplets and there's a high risk of transmission. When the person who doesn't have COVID wears a mask, then the risk of transmission is still quite significant. If the person with COVID wears a mask and someone who is infected does not wear a mask and they maintain social distance, the risk is lower. But important to note is that if both individuals, whether one with COVID and one without, if droplets are propelled and they're social distancing and they're well masked, then the chances of transmission are very low. So these measures remain to be very important. And I think if the world had strictly, followed these interventions, which actually look rather straightforward but very difficult for majority of the people to be able to comply, I think we would have probably made much more strides, so to speak. And I think one of the conversations we are seeing, especially with the UK, which is now slowly emerging out of lockdown, they have a very good vaccination coverage. Currently, at least more than 60% of the adults in that population have already received at least one shot of, the COVID vaccine. But their drop in numbers is still mostly being attributed. Yes, a significant of it is happening because of the vaccine, but also because they are just coming out from a lockdown. So I think it's also going to be a space in terms of science to be able to look at, and understand very well, especially from countries even like Israel, where the COVID vaccines coverage is actually very good, and we are seeing people coming out of lockdowns and even starting to drop some of these mitigation measures. But I think as a country we are still very far from there. So the last prevention strategy, which I said I think I'm gonna highlight and talk about, is on COVID-19 vaccines, and I think this is the gist of our presentation. So I'll probably try and spend about 20 minutes, so that we leave the last 15 minutes of this hour to question and answers. I'm sure there are very many of these from you. So basically, to go through what is usually expected when a vaccine is being developed, and as I highlighted, we do credit China for sharing the sequence of the SARS-CoV-2, the virus that causes COVID-19, way early on at the beginning of the pandemic. And actually this was in early of January 2020, and this was shared with various countries and pharmaceutical companies, and it aided in the design and of a COVID vaccine, which is the first box that is highlighted on the left. Once vaccines have gone through the design phase, they do enter the clinical trials. So clinical trials have different phases. I think we've had this, you know, as the vaccines were being developed last year. So phase 1 clinical trials are mostly to assess the safety of these vaccines. So it's usually administered to a very small number of people. And then you go into phase 2. Once you have satisfactory safety data, then you go into phase 2 trials. Phase 2 trials are basically trying to look at, you know, are you able to mount an immune response? And it's important to also know that these trials can actually overlap. And then you go into phase 3 trials where you enroll thousands of patients. And basically what you want to do here is look at what is the efficacy of your vaccine. And when we talk about efficacy, so from a science point of view, it's like a randomized control kind of trial where you have a group of people who receive the vaccine and then you have a group of people who do not receive the vaccine. So they are more or less within the same, you know, environment. And so you follow them up over time and see who develops COVID, who does not develop COVID. And then for those who develop COVID in the two arms, you want to see who develops, you know, severe disease. And when you talk severe disease, it's usually disease that requires hospitalization. Either for oxygen, most of the time is usually for oxygen supplementation. And then, you know, once you have good efficacy data and the efficacy which had been set was a target of about 50% efficacy, and we've seen majority of the vaccines actually have efficacies well above 50%. And we'll have a bit more conversation about, you know, the issue about efficacy and what does that mean, and is it actually fair to compare the different efficacies of different vaccines. But one of the things we saw early on, even from this efficacy trial, is that even for people who had received the vaccine and ended up getting COVID, they did not develop severe disease. And as I said, severe disease is what will put people in hospitals, and most of the time is for oxygen supplementation. So the fact that patients do not develop, you know, severe disease after receiving, you know, these vaccines, despite the varying efficacy, is also a significant plus, at least for healthcare system. And then, you know, once you have satisfactory phase 3 efficacy trials, then you go into large-scale production, of course, you know, after getting the necessary regulatory approvals. And it's important to see, because I know one of the questions that will come up is what we've been seeing on social media and also on, you know, in the news headlines world over, the issue to do with clots and why the issue of clots has come up. You know, why wasn't it picked during, you know, the trials? And some side effects tend to be extremely rare, that you really have to give millions of people the vaccine to actually be able to pick up, you know, some side effects. And we'll talk a bit more about that in the subsequent slides. So I go back to the structure of the SARS-CoV-2 virus, which I had already highlighted, and I said a lot of emphasis is actually the vaccines which are being developed are really targeting, if you can see my cursor, the spike. So the spike is, you know, this structure that is protruding from the virus, and I said these spikes are very important because the virus uses these spikes to attach to the host, and for you to attach to the host, so that that is necessary for actually infection to be able to take place. So what you will find is that majority of the vaccines are basically introducing a protein that just looks like this spike virus. So they're not this spike protein. And your body is able to learn how to recognize it, so that if you're now exposed to the actual, you know, SARS-CoV-2 virus, then your body has already formed in antibodies, as well as what we call T cells, which are also important when it comes to mitigating infection. So the biggest question, and this is the difference between the different kind of vaccines, is how are we presenting what looks like the spike protein for the body to be able to learn? So there are different ways. So some companies have used what we call an adenovirus vector. So what that means is you're basically getting a protein that resembles this spike protein, and then you're putting it inside another virus. And this virus is the adenovirus. The adenovirus is usually a harmless virus, and at most what it will cause is a flu. And so you use this as a carrier to deliver this particular protein. And this is what the AstraZeneca vaccine, the Johnson & Johnson vaccine, and the Sputnik vaccines are doing. basically using a vector, which is the adenovirus, to deliver what looks like the spike protein. I'll go into a bit more detail. I know right now it sounds quite a bit of a jargon. The other way of, the other way in which other pharmaceutical companies have used to present what will look like a spike protein is using what we call messenger RNA vaccines. And this is what Pfizer and Moderna are doing. And basically what they're doing is, I'll go into the detail of how these particular vaccines work, but it's basically teaching the body to be able to make a protein that just looks like this spike protein. And then you're able to mount an immune response to that. The Chinese have what we call an activated virus vaccine, which in this case is actually the whole virus, unlike what the adenoviruses and the RNA viruses are doing. This one, they are taking the actual structure of what looks like the actual virus, which has been inactivated, and having that injected and letting your body be able to mount an immune response. So basically this explains that, and I'll go into each of the different vaccines, whether it's the mRNA vaccines or the viral vector. I think that's where the emphasis will be, because that is these are the vaccines which are being used, most popular being used around the globe, and probably what we are likely to get in the country. It's important to mention that the technologies which are being used to develop COVID vaccines are not entirely new, other than for the messenger RNA vaccines. That's a technology that is really new on the block. But the use of inactivated vaccines, majority, if not of us, probably children have all received one form of inactivated vaccine. The use of recombinant protein technology has been used before. Majority of us have received this. Even the use of attenuated or even the use of live vaccines is something that a lot of us have used before. Adenoviral vector vaccines have been used. And for those of us who remember, a couple of years ago, we had an Ebola epidemic in West Africa. And we saw a lot of acceleration as well to developing a vaccine against Ebola, and they actually used the adenovirus technology. So really not new technology. Majority of us have received a form of a vaccine that uses this kind of technology before. Probably what stands out is the mRNA vaccine, which is being done by the Pfizer and the Moderna, as basically new technology. So it's important to also understand this, even as we start to question vaccines and the issue around vaccine hesitancy. So what happens? So I'll go into more specific vaccines. So I think all of us know, and we have heard from the Ministry of Health, they do plan to procure Pfizer vaccines, through the African CDC mechanism. We all know the vaccines which are currently in the country are the AstraZeneca vaccine, and this came through the COVAX mechanism. So it's important to understand how does Pfizer vaccine work, how does Moderna vaccine work, and these vaccines basically use what we call a messenger RNA. So what the messenger RNA does is that it has information, and this information your host cells use to make proteins that resemble that spike protein I was talking about. So once injected, the mRNA will use the host's ways of making proteins to be able to generate a protein that looks like the spike protein, and then your body will now start forming antibodies as well as T cells, which are part of your immune defense. And this will be maintained so that if you're exposed to COVID at a later time in the future, once you've already developed these antibodies and T cells, then they are able to prevent an infection, or as we said, prevent severe disease from occurring. A lot of myths around mRNA vaccines, especially given that they're the new kids on the block. There's also something locally that is going on social media, especially after the government said that they're considering, rolling out the Pfizer vaccine. So it's important that, number one, these vaccines cannot cause COVID infection itself. And this is because, as you have seen, you're not introducing the whole part of this vaccine. You're only introducing what we call a messenger RNA, which is literally, it's coming with a message. If I can try and break it this down further. And the message is, it will use the host to be able to make proteins that resemble what we call the spike protein. I can go back a bit. This is what I'm referring to. So they make proteins that resemble the spike protein. So they're never making the whole virus. So it can never give you the full, actual infection. And once it does this, then your body is able to mount an immune response. It starts producing antibodies as well as T cells against that protein. And in that way, if you are exposed to the actual COVID infection, then your body will be prepared to be able to mount an immune response. So the other myth that has been there is that will it modify the genetic makeup? That's another false myth out there, because remember, this mRNA vaccine, first, it does not enter where the DNA of the host is, so it doesn't get to the core of the cell. And immediately once the mRNA vaccine has produced these proteins, then it's actually broken down using the host cell mechanism. So it can't cause an infection, it will not interact with the DNA, it will not change genetic makeup, and it's not, because the video that I was doing rounds yesterday, I think was talking about genetically modified, sort of vaccine. So it has nothing to do with the host DNA. It's just a messenger that does not even get to interact with the host DNA. So I think that's very important, especially when it comes to, the myths around the use of the mRNA vaccine. And in this case, because of what we're likely to get is the Pfizer vaccine, those are just myths. Now, the AstraZeneca vaccine, the Johnson & Johnson vaccine, Sputnik also falls in this same category. These are the adenovirus-based vaccines. And as I had mentioned, is that these vaccines, basically what happens is that you're using another virus to carry this information about COVID, a part of COVID, putting it in a virus and then having that injected so that you're able to again mount another immune response. Again, the immune response is, production of T cells as well as production of antibodies. All these are just your body's immune response. So that if you're then exposed to COVID virus, as you can see below at the bottom right, then your body is already prepared and has already formed antibodies as well as T cells to be able to prevent an actual infection, but if infection happens, then probably asymptomatic or mild disease. So basically, that's how these vaccines work. In this category, as I mentioned, we do have the AstraZeneca vaccine, the Johnson & Johnson, and the Sputnik. This is a slide that I have not put here for the purposes of comparing effectiveness. And the reason I say that is because a lot of these vaccines were tried in different countries, in different times of the pandemic. And so you really can't say that one vaccine will be better than the other in a different population if it was actually not tried there. So we know the Oxford AstraZeneca vaccine, one of the clinical trial sites was in Kilifi at the coast. But when you look at where Moderna and Pfizer vaccines were actually tried, so if you go back to the history, it was actually right towards the end of the first wave. The number of COVID cases were on the lower side. I don't, at that time, the various variants we are seeing were not as widespread as we are seeing today. So it becomes very difficult trying to compare the efficacy of these different vaccines, especially if they were carried out in different settings. And that's why you find countries like, South Africa initially decided to roll out the, Johnson & Johnson vaccine, and because it was a clinical trial site, one of the sites was in South Africa, and they had the data on the South African strain. And so when you look at efficacy and how does this correlate in terms of rolling out vaccine, it's not simply looking at 95% efficacy, 76% efficacy for maybe AstraZeneca in the US. You really have to also take other things in mind. But I think the most important thing about these vaccines, I will emphasize again, is their ability to be able to prevent severe disease. which is very important because then that means we have less, hospitalization and less strain on the, resources that we have. Another major difference of these vaccines is you will realize the vaccines that are mRNA require rather lower temperatures than the usual temperatures we have for other vaccines. And as I said, this is a newer technology. So, Pfizer being stored at -70, Moderna at -20. And this is because the mRNA that is being used is being stored in what we call lipid nanoparticles. And for you to actually have viability of that vaccines, then they require much lower temperatures. So even as the government is thinking about, rolling out the Pfizer vaccine, and I think we all heard this in the media, of course, you will need extra resources for you to be able to maintain a cold chain. And basically a cold chain is maintain this temperature from manufacturing until the time when it gets to the target health facility and to the individual in whom it's being administered. I think the other big thing that has been going around with these vaccines has been the issue about side effects. Majority of the people who do get the vaccine will mostly complain about pain and swelling at the site. If you go back to the pictorials I had put up initially, for example, if you're being given the AstraZeneca vaccine, the Johnson & Johnson vaccine, I said this is usually put in another virus, which is an adenovirus that causes very mild flu-like symptoms. And so at times patients, we might get chills, might get fever, but they're usually short-lived. Majority will have resolved by 24 hours. Some people might feel a bit of tiredness, some will feel a bit of headache. And also some people have completely no side effect whatsoever. So even as we talk about side effects, and this has really been magnified and has come out very strongly with the COVID vaccines, we need to also realize that we do have not only vaccines, but also a lot of medications a lot of us will take over the counter also have potential side effects, which are mild, and some of them can also be very severe. So the big elephant in the room is the AstraZeneca and now the Johnson & Johnson vaccine being associated with blood clots. And I said I'll probably spend a few minutes, maybe the next 2 minutes, talking about this so that I can end the presentation and allow time for questions. Is the concern about blood clots. The issue about blood clots, let me first mention, it is an extremely rare side effect, and we've had publications recently for us trying to understand the mechanism in which vaccine cause clots. There's a publication in the New England Journal of Medicine that has given us a lot of insights in terms of trying to understand this very rare side effect. As I mentioned, the reason this was not picked during the clinical trials, especially even in phase 3, is because it's taken vaccinating millions of people to actually get to see this very rare side effect. Of course, what this has led to, for example, the pause in the vaccination of the use of the Johnson & Johnson vaccine in the United States. Some European countries have altogether stopped the AstraZeneca vaccine. Some of them have modified and said, give it for people above the age of 65. And this is because the very rare cases of, clot formation were realized among, younger people below the age of 50. Majority of them were female. But even as we talk about clots, and when it comes to its association with the AstraZeneca vaccine, as I mentioned, it's very rare, and I'll show you some of the data in the next slide. But also to mention that a lot of the common drugs that we probably use out there for women who are on contraceptive pills, they actually have a higher potential for developing blood clots, much more than the risk of getting the AstraZeneca vaccine. If unfortunately one gets COVID, their chances of developing a clot are much higher than from getting the COVID vaccine. And in this case, we're talking about the AstraZeneca and the Johnson & Johnson vaccine. So by the time the United States was putting a pause on the use of the Johnson & Johnson vaccine, they had reported about 7 cases of clots. Actually 6 cases, and as I had mentioned, all these were in women under the age of 50 who had developed some type of clots. And the reason why we are saying this is rare is because this was after administering the vaccine to almost 7 million recipients. because remember the Johnson & Johnson vaccine is a one-dose vaccine. And so it took, vaccinating 7 million people to actually see this side effect. And as I mentioned, it's very rare, and a lot of countries are not weighing the benefits versus the risk. As you have seen, the pandemic has, really taken a very huge toll in terms of mortality, not only at a global level, but even locally. So people have tried to go further and try to characterize and, talk to people out there to just gain an understanding and an insight to, why is there vaccine hesitancy. And number one that is coming out is the issue about potential side effects. But this is mostly driven by a lot of myths and a lot of, I think science and researchers have really been put to task around this, and trying to explain to the population the need of having these vaccines. Yes, there are these side effects, some are extremely rare, but given what is happening from a global level, you're probably better off getting the vaccine. One of the other questions that's coming out very strongly is the issue to do with vaccines in pregnancy. It is actually recommended. There's no contraindication and of giving these vaccines in pregnancy. And actually what we are seeing from, it's actually being seen world over, including locally here, is that some women who are pregnant, and especially in the last trimester, who get COVID, we've seen a few of them who actually develop quite severe COVID. And we're really trying to understand, what is it with COVID in the last trimester. Majority of them, they do well. They only have mild to moderate symptoms, but we've really had also quite a significant number requiring ICU admission and mechanical ventilation. And this is ladies who are initially very healthy, very young, in their late 20s or in their early 30s, developing COVID in pregnancy and developing quite severe COVID. So again, looking at what we know about vaccines, we do not see the risk that is, we do not see a potential risk. And when we try to weigh between, giving and not giving, the recommendation currently is we give vaccine to pregnant women to be able to, mitigate this risk, especially of getting COVID within the third trimester. And the other issue about COVID vaccine, I think I've mentioned that, is, COVID, and when it comes to the issue of lactation. So there's no contraindication if you're lactating or breastfeeding. You can safely receive the COVID vaccine. It will do no harm to your child. I guess the biggest question people will ask, did we have trials in pregnant and lactating women? Usually, ethically, this is not a group you would put in these clinical trials. And extrapolating from vaccines we've used previously, we do not see what the potential harm to either the mother or the unborn baby will be, or even during breastfeeding. I won't dwell too much on this because from here henceforth, the slides are basically not mine. I borrowed this from a presentation we had from the Ministry of Health. And I think it is all out there in the public domain. We are in the phase where we are currently rolling out COVID vaccine. We did early in March. This began with the rollout of the AstraZeneca vaccine, which came through from the COVAX mechanism, which is led by the Global Alliance Initiative for Vaccine. That said, I think the vaccine numbers are somewhere well over 700,000. And of course, then there's a question that I know all of us had this in the media yesterday, that there is likely to be a delay in getting the second batch of the AstraZeneca vaccine. And so the question is, then what will happen? When these vaccines were tried out, no one tried giving first dose AstraZeneca, then second dose Pfizer vaccine, for example. So, but we know that after you've gotten even the first vaccine, about 2 to 4 weeks, you develop a very good immune response. There is some protection that is offered, but then the second vaccine, for example, AstraZeneca, of course, it does boost that immune response and offers better protection. Some countries where they've stopped the use of AstraZeneca, especially in Europe, for patients who have already received one vaccine, are actually now considering, giving an alternative vaccine as the second vaccine. So a lot of things developing, literally on a daily basis when it comes to issues to do with vaccines. So there's a national COVID-19 deployment and vaccination task force. It has, various subcommittees within that. I won't go into the details of that. And we are currently in phase 1 of the rollout of the vaccine. From these slides, this was initially when it had only targeted frontline healthcare workers, as well as essential workers and what they are calling critical workers. But we've seen that, with the low uptake of vaccine, these criteria are being expanded to include people above the age of 58 years in this particular group. So I will pause there and maybe spare the remainder of the time to answer any questions that you may have. So I will stop there and hand over to Elijah. I don't know whether we go through questions on the chat or how you like to do this.
Yes, thanks a lot, Dr. Gaitho. So I'll read the questions for you and then you can answer them. So I've seen quite a number of questions, but most of them were actually answered during the presentation. But I'll start with the first one. A relative was given the vaccine and a few days later, he tested positive for COVID. When does the vaccine start being effective?
All right, so thank you for that question. I think it's one of the things that just alluded to the end of the presentation, and we've seen that happening a lot, where people are developing COVID after receiving the vaccine. So remember, we said you need to mount an immune response. That mounting of the immune response does not happen immediately. You need to give it about 2 to 4 weeks. Again, for you to be able to develop a significant amount of antibodies and T cells to be able to protect you. So that does take time. Number 2, ideally you still would require a second dose. In this case, I know we are talking about AstraZeneca because that's what we have in the country. And so on average 2 to 4 weeks for you to have some form of protection. So it's not surprising to see someone develop COVID, a couple of days or even a week after they've just received the vaccine. And that's why we still emphasize, and that is why, as much as this talk was just on vaccines, I went back and said, the prevention mitigation strategies that we had put in place still remain, and they need to continue.
Yeah, thanks a lot for that. I think there's also the question around, people with underlying conditions. And I can see a question here. So someone is asking, my mother is 82 years old and has a heart condition. Can she be vaccinated?
Yeah, so that's a very good question. So we don't have any, actually, those are the people whom we need to vaccinate. It's people with underlying conditions. So whether you have heart disease, whether you have chronic kidney disease, whether you have diabetes, where you patients who even have cancer, we don't have, those are the patients who are at risk of developing severe disease and even critical disease, and we've seen that. And so, as I said, weighing the risk versus the benefit, they're better off receiving the vaccine.
Okay, thank you. So someone is mentioning that a relative received the vaccine and developed complications and eventually passed on. Wondering what happened because they understand that they had blood clots. Was it caused by the vaccine?
All right, so it's difficult to actually comment on that, having not have attended to this particular relative, and my condolences for the loss. But of course, you need to look at things also quite holistically. The first thing I would actually, ideally, I hope that particular health facility did report that to the PPB, because that is actually reportable. So if someone does report, does experience side effects, or if anything happens to an individual after they have received a vaccine, even if it is a road traffic accident, it's supposed to be reported, and it's up to the Pharmacy and Poison Board to assess what we call causality. Was it associated with, the administration of, the vaccine, for example? So it's very difficult for me to actually comment, because even when we say clots, how are those clots, how are they diagnosed? How did they present? What are the side effects? How long did it happen? There are so many things that go into trying to determine causality. So I think there's a bit of paucity of data when it comes to that particular case. So the best recommendation I'd give is to follow up with the health facility where this vaccine was administered.
Thanks a lot. So a question here about the standard timeline for vaccine development. I think initially it was mentioned it will take almost about 1.5 years, but the vaccine has been made available way before that time. So the concern is, was the process compromised?
Yeah, I wouldn't say the process was actually compromised. So we also need to understand that we are in the middle of a pandemic and there has been loss of life in the millions. And I know processes have been expedited. And when you look at from my slides and what I had actually presented initially, is that, when you're taking a vaccine, majority of the vaccines, you'd wait for maybe a phase 1 trial to come to an end before you go to phase 2, but it also allows for a bit of overlap. And I think the overlap did help, shorten the time in which these vaccines were were developed and made available. The other thing to note is that they have not received, like full approval. They have received what we call emergency use authorization. And this is because, as I had mentioned, we are in the middle of, a pandemic. And for us to be able to mitigate this, because for the last 1 year, we are still continuing seeing, increase in the loss of life. And now we are starting to see new variants to work. And of course, you want to mitigate this as soon as possible so that then you are able to bring an end to more or less the loss of life. And this is something that the vaccines have shown they're able to do. And so I wouldn't say that the process was hurried without any due diligence. It was fast-tracked, yes, and that is because we are, smack in the middle of a pandemic.
Okay, thanks. For a person who has recovered from COVID, how long should they wait before they are vaccinated?
Yeah, so that's a very good question. So for someone who has actually recovered from COVID, I will answer these questions in 2 parts. So usually the recommendation that we are giving is that once the acute symptoms have actually resolved, whether you are having cough, fever, and all that, they have resolved, you're out of isolation. Once those symptoms have actually resolved, then you can actually get a COVID vaccine. Now, it's a bit different for people who have maybe received what we call convalescent plasma. So patients who, and this must have been done in an inpatient. So someone who had been admitted, received convalescent plasma. Those ones, the recommendation is wait for a bit longer, usually up to 90 days, because basically for them, convalescent plasma, you are basically infusing antibodies from someone who had recovered. The other question we see a lot around is, people asking, does a vaccine offer more protection than a natural infection? It's still something that science is really debating because, again, the vaccines are supposed to mimic an actual infection. But also what we have seen is also the emerging variants, and there's still a very small chance, even after you have received a COVID vaccine. I mean, you've gotten a natural infection, you can get another infection with COVID. So to answer that question, just wait for the acute symptoms to be over. If you received specific therapy or if you're in the inpatient and you got convalescent plasma, the waiting time is a bit longer. But for most people, especially for those who are in home isolation and they're well after 2 weeks, they can go ahead and receive the vaccine.
Okay, thank you. Is there a risk of anaphylactic reactions?
Yes. So remember, and I know, as I mentioned, the side effects or the adverse effects of the vaccine have really come under a lot of scrutiny. And of course, this was a concern, and there have been very, very few cases which have been reported all over the world. And I just wanted to mention that anaphylaxis reaction is your way of your body, reacting to something which has been introduced that is foreign. It doesn't have to be a vaccine. We see that even happening with some antibiotics which are commonly used, which even some of us, will go and get over the counter. So it is something that potentially can happen not only with vaccines, but a lot of the commonly used drugs out there, but in particular for the COVID vaccine, it can happen, but it's extremely rare, and where it has happened, it's people who have had significant history of allergies.
Okay, thank you. So is there, how many times within someone's lifetime will they need to get the COVID vaccine?
So that's also a very good question, and it's something that science is very closely following up, because even for the people who have fully been vaccinated, we don't have any locally. But in the countries where they have individuals who have been fully vaccinated, remember, even the patients who did take part in the phase 3 clinical trials continue to be followed up to try and see this protection lasts for how long. So the fact that we don't know for how long for sure, Pfizer last month did a publication and said for sure for 6 months you're fully protected. So the data is coming, but it is coming as time, with time, and it might end up being just like maybe the influenza, vaccine, which people get annually. I think with time we'll be able to tell whether people will require, booster vaccines of COVID, and how often that will be done.
Okay, thank you. And can the vaccine be given to children?
So that's also a very good question. So at the moment, the vaccines are not being given to children. The vaccine that is from the emergency use authorization, most of the vaccines were tried in people above the age of 18 years. Pfizer was tried 16 years. There's currently a clinical trial that is going for the Pfizer vaccine for children ages 14 to 16 years. But at the moment, the recommendation is they were not included in the clinical trials, so we are not giving the vaccines to people below the age of 18 years, with the caveat of Pfizer, which lowers the age to 16 because it included up to 16 years in their clinical trial. So, but the good thing is that for majority of the children who get COVID, most of them either are asymptomatic or a few develop bad symptoms. We've not seen children coming in, especially in our local setting, with what looks like severe disease.
Okay, thank you. Now you mentioned briefly the issue of mixing and matching. So someone who took a different vaccine then comes into Kenya, can they take the AstraZeneca vaccine?
Yeah, so that's a very good question to actually ask. And it seems that is the way that we're actually going to head. And I'm not saying that backed by evidence, because the clinical trials did not mix and match vaccines, so to speak. But when you think about it from a scientific point of view, and when you look at how these vaccines are working, as I mentioned, you will see most of them are targeting to produce what looks like the spike protein, which and if you're able to do that, because even subsequently, even when if for example people will require boosters, does that mean then you need to get what you got originally? Can you get different? I know we'll start getting data on that, because it seems that's what some of the European countries have started doing for those who have frozen the use of AstraZeneca vaccine. But in terms of, is it as equally effective from a scientific point of view? We expect it to be, but we are still waiting to see what the data is going to show. And there's also a possibility that Kenya might actually head in that route, especially given that India has, frozen the export of the AstraZeneca vaccine, at least because most of the manufacturing is being done at the Serum Institute of India.
Okay, and what happens if someone misses the second dose? What are the implications?
Yeah, I mean, so in terms of implications, so remember, as we said, that even getting one dose of the vaccine 4 weeks later, you do have some form of protection, all right? It's not as great as compared to someone who gets 2 doses. So you getting 1 dose, the only implication is that, yes, you have some form of protection, but it would be better if you got a second dose. The other question that is coming up is the time between the first dose and the second dose. And we are starting to see publications of people saying, fine, you can give the dose at 8 weeks, but you might even get a better response if you delayed for 12 weeks. And that is, data that is coming up, because again, that's the concern that people have especially for those who received the AstraZeneca vaccine, and they were told you'll get your next jab in 8 weeks. We know there's going to be a delay, and how will this delay impact the efficacy of the vaccine overall? And now we are starting to see data that even when you delay getting that second vaccine to 12 weeks, that is what the data is showing, you might even get a better immune response and better protection. So getting one vaccine, it will just give you protection that is maybe suboptimal compared to getting two doses.
And someone who had blood clots in the legs a few years ago, is there additional risk with taking the Johnson & Johnson and the AstraZeneca vaccine?
Yeah, so that's a very good question. So you'll find that majority of the people who have actually gotten clots in the past, of course, there's the assessment of risk of developing clots that is usually done. So what was the reason of why they developed clots in the first place? So that's usually important. Of course, we know if you have clots in the legs versus if you have clots in your brain or if you have clots in your lungs, the risks are usually very different. And for majority of people who have had clots, on chronic blood thinners, and you're probably on blood thinners for a very long time, and for some people even for the rest of your life. So it significantly, especially if you're on blood thinners, it significantly reduces that chance. The other thing you look at from us understanding the physiology behind, how these clots actually form, then you need to also further stratify, what is the age. We know it's common in young people. Then you look at, what is unfortunately, females have a higher preponderance of developing those clots. So there are a lot of things you'd have to take into consideration. What I would say is that maybe for someone who has had a history of clots, especially if it's a clot either in your brain or a clot in your lungs, you'd want to have that discussion on an individual basis, with your primary physician, so that they have a better understanding of what the risk would be for that particular person. But the risk still remains to be significantly low.
Okay, thank you. And does one require to have a COVID-19 negative test before taking the vaccine?
Good question, and the answer is actually no. And I'll say that because relating it to the initial question that was asked around, so you've given someone has gotten COVID, and let's say, for example, you're in home isolation. The first thing to understand is you do not need a negative test, which happens a lot out there for people to end isolation. So people with mild or asymptomatic disease, we know they're no longer infectious beyond a certain duration. Now, the other thing we've learned from science is beyond a certain time, you might continue shedding dead virus. And if you do a COVID PCR test, it will continue being positive. So there are people who end up having a persistently positive COVID test for a very long time, and it can even be months. So we usually say there's no indication for chasing a negative COVID if you had a positive COVID. And even when your COVID turns negative, it can very easily be positive if you are to even repeat it maybe 5 days down the line. So the answer to that is no, provided you have recovered from COVID, your acute symptoms have resolved. Whether the COVID remains positive or negative, you would still go ahead and receive a COVID vaccine.
Okay, and is the use of, I know you mentioned this, there's someone wondering how much you're using convalescent plasma for critically ill patients.
Yeah, so the use of convalescent plasma, with more evidence coming out, it actually does not make a significant clinical difference in terms of outcome. Actually, at Aga Khan, we don't use convalescent plasma. This was being used quite a bit, I know, at KU, and that's why I brought it up. But from data, we are seeing it has no, for example, mortality benefit even in the critically ill patients.
Okay, and if someone is fully vaccinated, is it still necessary to continue wearing a mask?
Yes, it is. As I have already mentioned, you need to get to a level where a significant number of people in the population do have been vaccinated to achieve what so-called herd immunity. Currently, even for people who in Kenya, I'm not aware of people who have been fully vaccinated, but even when you get to full vaccination, as I said, the mitigation measures will have to continue for some time because they will actually work synergistically for us to be able to, see a public health, impact. The other thing is we are starting to see a lot of variants coming up, and some of these variants, we have very minimal data to see how they compare, especially with the different vaccines. And so there's that caution that, some variants might end up breaking through these vaccines and ending up causing, severe disease. We already know that even when you've been vaccinated fully, there's still a risk of developing COVID. As I mentioned, yes, you're likely to develop mild and not severe. But if you develop COVID and you interact with someone who is not immunized, then you're also putting them at risk of developing severe disease. So it's really a public health approach, and this is why I mentioned it's a global pandemic. So even when the US and the UK are really pushing, their vaccine numbers up, of course, vaccine equity. For the world to say that we are making progress, it will have to be a global, all over, whether you're from, Southeast Asia or whether you're from Africa, you really need to have the population reached when it comes to vaccines.
Okay, and a question here about recovery after COVID-19. Is there an impact on physical activity, and what are the recommendations about physical activity after a COVID-19 disease?
Okay, so that's a good question, but then it's also a very broad question because it also depends on, how severe was the COVID, disease. People who develop mild or asymptomatic, or let me put people who are just on home-based care, a significant number of them will actually have residual symptoms. And we've seen that, and it's actually been published that majority of patients, even with mild disease, about 3/4 of them, even after they have recovered, they'll have residual symptoms. For some of them, it's cough, which can persist for several weeks. For some of them, it's fatigue. And one of the ways, especially even for patients who even had mild COVID, they realize you're going upstairs and, it's very exhausting. So even after you're fully recovered from COVID and you're out of isolation, but for majority of people, even if you had mild disease, they don't get to 100% immediately. Of course, for patients who were in the inpatient and required oxygen and were admitted for oxygen supplementation, of course, it's going to be a gradual process. And even when they are discharged home, one of the advice that we give them is that we don't expect you to go back to your routine activities. You can't immediately start exerting yourself. And the most important thing is also listen to your body.
Okay, thank you. What are the effects or long-term effects of taking vitamin C and zinc tablets when you are not actually COVID positive?
That's actually a conversation about zinc, vitamin C, vitamin D that we can literally, it can take a very long time. But let me just say, if you're supplementing this because you're not able to meet the recommended daily allowance, we don't expect to see any effect, because these are basically, supplements, so to speak. So they're supposed to be supplementing what you're not able to achieve in your nutritional diet. So that would not have any effect, so to speak. But whether they have an impact in role when it comes to COVID-19, I think that's a debate I don't want to open that Pandora's box.
Okay, yeah, and with regards to people with either HIV, and I've also seen someone asking if they're on triamcinolone injections, is there any risk for them to take the vaccine?
Actually, the vaccine is recommended. There's no contraindication. And it's also important to note that some of the vaccine trials and the Johnson & Johnson vaccine, which I had mentioned, was also done in South Africa, did include patients who are HIV positive.
Okay, thanks a lot. Yeah, so I think the last question I'll put to you. I think someone here was asking, we've been taking vaccines for very many years, so why all the why all the discussions around the COVID vaccines, very many myths and facts being paraded from very many different quarters?
I think I'm also asking myself the same question, but I think it's because of it's received a lot of limelight, and of course it's been on the news every day. Everyone has been talking about, when will we get some form of normalcy? How soon can we get some form of normalcy? And of course, vaccines have been touted to be the game changer. And I think because of all the scrutiny, and I think we are seeing, vaccine development unfold in a world where social media was not, what it is today as it was back then. So information, whether truthful or, myths, will move very fast. And I think that has created a very huge, debate around the COVID vaccine. Yeah, so I mean, as I mentioned, anything you take in that is foreign, whether it is, even that vitamin C or vitamin D, and it probably has a preservative and your body reacts to it, it has the potential to give you some form of side effect. Even that zinc can give you diarrhea. It's not like, anything that you introduce, your body can react to it. Some people take milk, and because it has lactose, they react to it and they develop a bloated stomach. So, side effects is something that is not unusual, but as you've said, it's really, been blown to some extent way out of proportion. But then again, it's also created a lot of public awareness on vaccines.
Okay, thank you. I think just the very last one, I think it will be very important for us to just hear your comment about the use of some drugs that were very little known about, but came into the limelight with the pandemic. So ivermectin, hydroxychloroquine, and azithromycin.
So that's a very good question. So number one, ivermectin, even the manufacturer of ivermectin has said do not use it for COVID. It is not recommended. There is absolutely no evidence that ivermectin plays a role in the management of COVID. The use of hydroxychloroquine, it was used initially. Evidence showed it has no role. It actually gives you more adverse outcomes, and especially effects on the heart rhythm. The same thing happens when you combine azithromycin and hydroxychloroquine, which is what people were doing initially. I've seen a very huge conversation on social media on the use of azithromycin. Azithromycin does not treat viral infections, so it is not indicated unless someone is suspecting there's a superimposed atypical pneumonic process, which is not common even with COVID. And I can tell you for sure, because we see that a lot, people go to the chemist, not only azithromycin, they come here when they've gotten Xanax, okay, let me not name trade names. They've been on cefiroxime, they've been on, amoxiclav, all sorts of antibiotics to treat COVID. So, I mean, the take-home message is a viral infection. And for majority of the people, it's basically that is all they do have.
Okay, thanks a lot. So we've come to the end of this session. I think it was quite enlightening. I believe we now know much more about vaccines. And I think if there were any one of us who are hesitant about taking the vaccine, I think we hope that has now changed. So we'll just give you, Dr. Gaitho, a chance to give your closing remarks so that we can wrap up this session.
Yeah, I think maybe just to say thank you for the opportunity. From a personal perspective and also from experience that we have seen, over the last 1 year, with COVID, COVID can cause quite severe disease. As much as we keep saying, and especially for the young people, if there are any who are listening, I think I did mention, the issue about masking and all that. Until vaccines are available to you, I think it's extremely important to continue, practicing these mitigation measures. From a healthcare perspective, we do get, quite, overwhelmed, especially when we are seeing waves like we're currently seeing in the third wave. And I think one of the ways in which the listeners who are here can, really help the healthcare workers is by, abiding to these so-called mitigation measures. And age is not always on your side. And we've seen very young people develop very severe disease, and you don't know who will. So I would actually say, if you get the opportunity to get the COVID vaccine, just go ahead and do. Get the COVID vaccine. Side effects are extremely rare. These are safe vaccines, and they will, prevent you from hospitalization and even, worst case outcomes, so to speak. So thank you very much, and wish you a lovely afternoon.
Okay, thanks a lot, our attendees. This was a very good webinar with, about COVID-19 vaccines with Dr. Douglas Gaitho, who's a consultant pediatrician and infectious disease fellow at the Aga Khan University Hospital. We want to thank you, Dr. personally, and also for the Aga Khan University Hospital team for allowing us to have this session. Yeah, from UAP Old Mutual, where we do thank you for joining us for this session, and we also encourage you, please get the vaccine once you become eligible. Thank you and have a good afternoon.